All right, good morning, everybody. I don't know where to look, to the camera, to live audience. First of all, good morning, and I'm delighted that we have people coming in live, and hopefully we'll have more and more of transition to the live format, which I'm sure we all miss. But we'll still have the virtual because we have also centers further away. But I think it's fun to have everybody gathered together. So it's really with extreme delight that I welcome all of you to this special day of celebration of scholarly work of our residents. This year, and the plan is to continue with this tradition every year in the last grand rounds, which, by the way, this is not going to be the last grand rounds. We had to switch, but the plan is to have the last grand rounds of the year celebration of scholarly work by our residents. So that tradition is starting today. And today the focus will be on quality improvement projects, although you'll hear also more traditional clinical research. The presentations that you're going to hear today are all peer selected. So I congratulate those of you who are presenting today for this achievement and for the wonderful projects that we're all going to hear about. I'd like to give special thanks to Dr. Susana Acula and Sergio, not only for arranging this day, but also elevating quality improvement activity. And this is not at all Susan La clapping over here, for elevating quality improvement activity in our department from the abysmal state that it was to a very respectable level that we're in. So without further ado, I pass the torch to Susana Acula and Sergio. Thank you very much and congratulations to all of you.
Can everyone hear me? This is a very lively crowd. So for those who are not in lecture hall 1, you have fear of missing out. Yeah, now. Anyway, I do want to say thank you very much. This is the purpose of this grand rounds is to really demonstrate your work and to really showcase your work and the diligence that you have in and your dedication for quality improvement. So we have selected a couple of presentations, and of course we will never ignore clinical research. So it'll be last but not least. So it's my pleasure to present our first project, which is called, let me see if I can actually share the screen. It will be the copy curriculum, which is a QI project within a QI project, which is actually something that I took from Dr. Perk when he was saying, let's do a QI project, I have a QI project. And so the initial presenters will be Sergio, Liz, and Shruti. Thank you.
So for this project, so basically it's the principles like we want to do a project of QI about QI curriculum. And that's coming from like a basic idea. So trying to improve the quality improvement in the department. So for this, we had just basically two aims. One was to increase the number of residents participating in QI projects, but also to increase this number with resident initiative PR projects. So for this, we trying to just do some basic measurement, just like basically trying to take the percentage of these neurologist residents in the projects, but also that actually they are starting these projects. And we had like some balancing measure that we're trying to do for this is basically residents that decide they want to do more traditional research, and they have quoted research or abstract presentations. we want to see also the percentage of faculty members naming as mentors. And also we want to see the residents' perceived satisfaction with the curriculum. So for this project, so we had the leads for this is going to be in the faculty part. It's going to be Dr. Peck, Dr. Kula, and Dr. Lo. And we had a resident team. It was basically Dr. Sivakumar, Dr. Kukusus, Dr. Monahan, and me. So the first thing it was trying to identify the problem is that we had very few quality improvement projects initiated by the neurology residents, and we did a fish pond. So for this, we need to just categorize, and we had like kind of strong ideas trying to understand how we can, what was the barriers for this problem. So we identified the providers, staff, the equipment, environment, the procedures, and the clinical decisions. And out of these different like kind of staff ideas, we highlighted the ones that are in red that we want to start working on those. So we highlighted the low faculty interest in quality improvement projects, the lack of formal education, the lack of protected time for quality improvement, the lack of a structured pathway for quality improvement projects. And then from these ideas, we want to address how we can improve this. So the first in principal aim was to increase the number of neurology residents with initiated PI projects within 6 months periods. And we had two primary drivers. One is to develop a structured pathway, and the other one was to increase the faculty interest in quality improvement projects. The secondary drivers for this was to select a quality improvement faculty, like faculty with expertise in quality improvement, and to develop quality improvement projects, curriculum on quality improvement. We also have the secondary driver that was improve the awareness of quality improvement as a necessary tool, and to increase the awareness of the benefits of the quality improvement. So we had specific ideas how to address this, and we offered the faculty development in quality improvement. We increased the access to the quality improvement projects, and we encourage development resident goals, and we're trying to involve the department on these projects. And we want to just increase exposure to the quality improvement projects. So for this, we basically trying to work, and we requested the attendants and residents to provide project ideas and to create a project bank. We involved the program director, Dr. Perk, and he basically emailed all the residents, and they make a requirement to for the residents to do scholar activity as a quality improvement. And we have basically our attendants, they were helping us to develop this project, Dr. Alo and Dr. Akula. And this is the bank that we created. There are different projects, and we have an attendant that was leading each project, and we're starting to basically tell the residents to self-assign to one of these projects. And some of these projects were developed completely, starting to work, and some of that that were basically on the dark shadow, were not developed. But that's an idea of how we were starting to work. For the first Pdsa cycle, so basically we came with some results, and we were able to involve 36% of the PGY2 class, 70% of the PGY3 class, and 100% of the PGY4 class, with only 2 exceptions in the PGY4 class, just because they were requesting to be same from the quality improvement, because they had traditional research. And then we had a second part that I'm going to be explained a little bit later, but this is basically our design results that I explained before. Just wanted to mention, additional to this, that the quality improvement projects had a heavy participation from Kings County, around 2/3 of the projects. 25% was from downstate, and 8% from minorities. So now in my partner here.
As a part of our preparation for our second Pdsa cycle, we started with a Gimbal Walk. Gimbal Walk is a structured walkthrough where you examine the process and not just the results, so not just the percentage of residents, but the process of the residents going through the QI. For our Gemba, we sat in on active QI project meetings, and we were able to find areas of improvement in the process as independent observers. There are some teams here who allowed us to sit in on their meetings, and we really thank you for including us. Our Gemba walks helped us expand our original fishbone. And as you can see, what was in red was what me, Sergio, and Hazel had identified as areas of improvement and important barriers. But we, as part of our second Pdsa, we wanted to increase PGY2 participation. So we recruited Shruti, who helped us identify the areas in green, which were more important for the PGY2s to focus our second Pdsa cycle. And I'm going to let Shruti take over for this is our fishbone. And with this fishbone, we were able to make a nice driver diagram.
So over here, we have the driver diagram for our second Pdsa cycle. On the left, you can see the primary outcome is to improve the sense of empowerment for PGY2s to participate in QAPI projects. The secondary drivers, we identified 4 of them, which are specific to PGY2s. We wanted to formalize recognition of PGY2s in their QAPI projects. We wanted to highlight their success. We wanted to improve the awareness of what's expected during a QAPI project, and we wanted to develop a curriculum. On this basis, we decided on 4 concepts of change. We wanted to acknowledge the residents who participated in QAPI by awards from senior administration. We have been posting things on Instagram, if you follow us on Instagram, to highlight the success stories of QAPI projects, which we've been doing for the past couple of days. We've been trying to develop projects that have short Pdsa cycles so that we have more awareness on what's expected. And we have required PGY2s to participate in QAPI projects so that we can better develop QAPI curriculum and a formal QAPI pathway. So these are the results that we got with the second Pdsa cycle. We saw that the PGY2 participation increased from 36% to 100%. PGY3s were unchanged at 70%, and there was 100% participation with PGY4s as well as pediatric neurology fellows. We also saw that there was increased participation at the Maimonides site from 8% to 22%. 2 of the projects that we saw were completed and finalized. And from these results, what we kind of determined is that we need more follow-up to prevent resident and attending attrition. We also learned that PGY2s are interested in QAPI projects, but the primary and secondary drivers are different compared to PGY4s and PGY3s. And as a result of this, requiring residents to participate in QAPI has improved our participation overall in all scholarly activity in the residency program. So this is, go to the next one. So that's about it. Does anyone have any questions, any comments?
Does anyone have questions in the group? Okay. I'm going to give you a softball question. Wait, let's wait for the Zoom. Does anyone have questions on Zoom?
No.
No. So the softball question I'm going to give is, this is a very unusual project. It's traditionally when I think of QI projects, I think of changing our clinical practice in a hospital setting. So because most of the time, these QI projects, when they involve the hospital, we always look at the lens of equity. So I'm asking you, how does your project affect equity?
Thank you, Dr. Law. That's a good question. Before I answer the question, I'd like to just remind everyone what equity means. So Equity is a concept that recognizes that everyone has a different circumstance, and it allocates the exact resources and opportunities to each person so that everyone has an equal outcome. And through this project, I realized that each resident has a different barrier or a challenge that is preventing them from participating in copy projects. So for example, if I could use a personal example, I kind of compared myself with another one of our residents who participated in QAPI, Robbie, who's not here right now, but participated in the Vertigo pathway. He was he kind of had an idea and he needed a formal pathway, he needed some support. But if I took my example, I needed a lot more guidance and support. But at the end, both of us had the same primary outcome. And this allows us to formulate a personalized approach so that each resident can have the same outcome and achieve the primary outcome. That's kind of what I was able to learn from this QI project.
Is there another question in the chat? No. Oh, I love questions.
Hi. So I noticed when you were collecting data on what attendings were participating, there were a few attendings who seemed to be shouldering a tremendous amount of the work and the weight of this and burden. And I'm curious if you have any thoughts on how to better flatten that burden and increase attending engagement on attendings who are currently not so engaged in QI.
That's a great question. I'm probably going to answer that because that's an attending question, I think. We need to have another stakeholders meeting with the senior leadership. I think that this is the first step, and in order to normalize the plane, we just need to have the skill set develop in all of our faculty. That was a great question. All right, so thank you very much for just doing that project and just presenting it. I do want to give you, everyone gets a trophy. So I want to give everyone a trophy.
Good morning. So the next presentation is going to be the pediatric presentation on rescue seizure medication prescribing practices in the clinic. So I'm happy to introduce Lakshmi, who's been working on this project with Theodora and Fatima. Thank you.
I think the desktop is already shared, no? It's already shared.
Sorry.
Thank you, Sajid. Good morning, everyone. I'm Lakshmi, Pediatric Neurology resident, PGY 3. So I would like to thank Dr. Chari, our project mentor, for your guidance and support, and Dr. Kula, Dr. Law, Dr. Perk, and everybody else here for giving us this opportunity to present this QI project in this grand rounds. So our QI project is on improving seizure rescue medication prescription practices in the clinic. Our team members are Theodora, Fatima, and our project mentor is Dr. Chari. So why did we choose this project? So we know that status epilepticus is one of the common neurological emergencies in adult as well as in pediatric age group. And in pediatrics, it has 2 to 7% mortality rate as well as significant morbidity rate. And any acute prolonged convulsive seizures, that seizures lasting more than 2 minutes, have the potential to progress into a status epilepticus. And any seizures lasting more than 5 minutes is unlikely to stop without medical management such as benzodiazepines. So that's why it's That's why the prompt treatment of these seizures are necessary to prevent the adverse outcomes. And that's why home rescue medication administration is an invaluable tool to prevent such complications, unnecessary admissions for prolonged acute convulsive seizures in pediatric age group. Not only that, appropriate dosing is necessary to effectively break those seizures. So in our project, the primary objective is to assess if the home rescue medications are prescribed in the pediatric patients with epilepsy and recurrent febrile seizures. Those are the indications. The secondary objectives are whether the appropriate dose is being prescribed or whether the seizure medication prescription is well documented in the EMR and is the prescription up to date in the subsequent visits. And the long-term goal for the study is, the reduction in number of breakthrough seizures, ED visits, and status epilepticus admissions. So we made a fishbone diagram. So we try to analyze what is the cause or what are the barriers in effectively prescribing a successful seizure medication prescription. So we categorized that into different categories, and resource factors are pharmacy issues. Pharmacy may not have the medication in stock, or there is delay in receiving the prescription, or sometimes insurance issues. That insurance may not cover the appropriate medication for the patient. And two new latest medications are intranasal diazepam and intranasal midazolam, which I'll be covering a little bit later. They need prior authorization. That is also a challenging part. Then the most important factor is people factor, which is physician factor as well as patient factor. All seizure rescue medications, are like controlled substances. So it needs to be sent by an attending. And we have seen a lot of prescription errors. Most common prescription errors that we have seen are with clonazepam. It's usually prescribed as clonazepam tablet instead of clonazepam ODT, orally disintegrating tablet. That is the seizure rescue medication, but that has been prescribed wrong many times. And then other factors are parents or patients must pick up the medication from the pharmacy. They may have variable health literacy and they may not understand the importance of the medication or how to administer the medication. And sometimes, especially in pediatrics, we have to prescribe one for school, and school may not understand how to give the medication correctly. So all those leads to child having breakthrough seizures, and child does not receive the rescue medication on time. So this is the overview of our project, and our aim or SMART goal is to improve the prescription of seizure rescue medication in pediatric patients or seizure patients. We are in our first Pdsa cycle, and the key metric we are trying to analyze is percentage of patients with epilepsy or acute convulsive seizure being prescribed with seizure rescue medication. I'll be talking about all the parameters in my coming slides. So we did a retrospective data analysis of UHP pediatric neurology clinic patients with seizures seen in our continuity clinic for a 3-month period from September to November. And we collected data on age of the patient, gender, epilepsy type, and we also collected data on rescue medication prescribed, what rescue medication was prescribed, and that is our outcome measure, and also date of the most recent prescription. So for our study, if the patient was prescribed with medication within last 1 year, then that is considered as an active prescription in our study. We excluded patients with unclear diagnosis, such as patients who are coming for the first visit. There is no clear diagnosis of patients. We excluded them from our study. We included patients with generalized convulsive seizures, focal seizures with secondary generalization, prolonged or recurrent febrile seizures lasting more than 5 minutes, and seizure clusters or seizures, more than 2 seizures in 24 hours. Those were the patients that we included. So there were 50 patient visits for seizures or epilepsy. 4 patients were excluded because of the unclear seizure diagnosis. 8 we excluded because of the seizure type, absence seizures, and myoclonic seizures because they are not really convulsive seizures. And out of the rest of the patients, 38 patients who should be prescribed with seizure rescue medication, only 25 of them were prescribed with medication, which is around 65.8%. Then rest of the patients who were not received any medication, 5 patients were seizure free for more than 2 years. So we haven't prescribed with them with any medications. 8 of them we haven't prescribed with any medication due to unclear reason. There were not clear documentation in the EMR of why the reasons are. It accounts for like around 21.2%. So we are trying to improve those percentages in our study. We analyzed the seizure type. 45% of the patients had focal seizures, 31% of the patients had generalized, rest of the patients had absence, myoclonic, and unclear seizure type, but we excluded those patients. The common rescue medications that we prescribe in the clinic, 65% of the patients we prescribe clonazepam, 20% of the patients received diastat or rectal diazepam, 2 out of 38% received Valtoco, which is intranasal diazepam, and 1 out of 38% received midazolam, intranasal midazolam, which is the nasolam. So those 2 medications are the latest FDA-approved drugs. Until 2019, there was only Diastat, which was FDA-approved, but for the last 2 years, they approved Valtoco and nasolam. That's why we recently started prescribing those medications. That's why the numbers are low. We did an educational session in our pediatric neurology department in our research meeting, and we educated our residents, fellow attending physicians about what are the appropriate medication, what is the dose of the medication, what is the age group we can prescribe each medication. We also discussed about how to administer the medication so that we can teach the patients on methods of administration so that they can administer it effectively. We also had dummy midazolam, Valtoco and nasolam in our office, so we demonstrated that among ourselves, and we can use that to teach parents as well. So what's next? So we will conduct another Pdsa cycle over 3 months, and we'll compare if there was any improvement in the rate of appropriate prescription and appropriate dosing. And our aim is to increase the prescription rate to 100% for convulsive seizures. Right now, we have included only pediatric neurology continuity clinic, but our plan is to extend the Pdsa cycles to pediatric epilepsy clinic and adult clinic, and we would be happy to give educational sessions to adult neurology residents attending regarding the newest, regarding what rescue medication needs to be prescribed. And the long-term goal is to reduce the number of breakthrough seizures, ED visit, and status epilepticus admissions. Thank you. Any questions?
Great job. So are there any questions to start from people who are here in the flesh before I open it up to virtual? Yes, Dr. Law.
Besides the scholarly requirement of doing a QI project, can you, this is a great project. I love it. It was much needed to be done.
Yeah.
What lessons have you learned in just participating in this project?
I learned a lot from this QI project, especially the fishbone diagram was very educational. We tried how to analyze the causes or the root cause of any problem, how to bring our thought process into action plans, how to implement that action to improve those outcomes. Those were very educational for me, and it was very interesting. So I would like to do more of like root cause analysis QI projects in the future for like more, if we see like more flaws, so that we can tackle it in the future.
Any other questions from the live group? Is there any questions from the folks at home? While you may be thinking or typing your questions, I have a question. Can you tell me, I'm curious to know how you got the idea to do this project, if there was a case in particular or an M&M that led you to be interested in this?
There was no case in particular, but it's just personal experience through our pediatric neurology clinics and adult epilepsy clinics, because for some patients we have seen being prescribed with many medications, and there were no clear-cut definition or clear-cut indication for any of this medication being prescribed. And some patients were prescribed clonazepam, some patients were prescribed diazepam. So we wanted to learn more about what are the clear indication and correct dosing, and how we can give equity to the patients by providing the benefit of the seizure medications.
Got it. So it sounds like future Pdsa cycles might look at how to really ascertain what's appropriate for a given patient and reduce some of the various.
Yes.
Dr. Anziska, the medications all may not have the same cost. But in terms of monthly cost of medication to the patient, does that factor in what you prescribe, presuming that the medications are reasonably equal in efficacy? Because costs vary a lot, and expensive medications, ultimately make more and more medications unavailable. Does that come into your prescribing medication? I mean, they're diazepam, clonazepam, etc. Nasal versus rectal. Do you look into the initial projected cost of this, let's say over a month period or 3-month period?
So yes, so for example, clonazepam, 30 tablets of clonazepam may cost around $50. But if you compare that with intranasal preparation, it might cost like $500 or $1,000 or a few $1,000s. But luckily, we have we can get prior authorizations for this intranasal ones. We can do prior authorization through CoverMyMed, and we can even do peer-to-peer talk to the pharmacy so that we can make them approve the medication for the patients. So we usually make sure that there is a prior authorization, and we usually make sure that the patient get this medication in our clinics.
But that does take extra time, and you're touching on an important issue of health equity in a population where it's not always easy to get the most
Yes.
expensive. So, so it is
Yes.
certainly something to collect data on in future cycles too.
Yes.
Sorry, another feature is the cost that the patient's family has to pay in addition to the authors, and that may differ again from medication to medication.
Could you say that again?
Is on the plan. Yeah, the co-payment on the part of the family for medication and the type of medication given also has to be factored as well as the prioritization. Studies have shown that families are bankrupted by co-payments. I'm not saying for medication for epilepsy, but for certain things. Do we know about the co-payment issue with these drugs?
I'm not really sure about the co-payment issues.
It sounds like
Maybe
it wasn't
Dr.
something you looked at in this cycle,
Yes,
but
yes.
you have some anecdotal evidence to suggest that it varies widely depending on insurance. But it can certainly be collected in future cycles.
Yes, correct.
This is a great point to think about in
Yes.
terms of cost effectiveness.
Yes, thank you, Dr. Francisca. I would include the cost effectiveness part in the upcoming PDSA cycles too.
Okay, and I think Dr. Cunningham has a question as well.
Do you have the thoughts or a plan on how you will assess the efficacy of your intervention moving forward? That is, how to measure pre or post intervention ED presentations or hospital admission rate. So in our upcoming PDSA cycle, we are gonna compare how many patients were prescribed with the rescue medications and were they prescribed with the appropriate dosing. So that's why we are going to check the efficacy of our intervention. And there is that is our outcome measure that we are going to check.
But I think it's
Yeah, we haven't included that in our study yet, but that's actually a nice point. We probably in our future, in our upcoming PDSA cycle, we can include that like ED admissions or status epilepticus admission following our intervention.
So just for those who couldn't hear, Dr. Chari made the point that you could also follow the patients who are prescribed a rescue medication and to see if in a certain amount of time they did come into the ED for or the hospital for breakthrough seizures. So
Yeah.
This is a great reason why we do these presentations, is to get the input from other people about potential process and outcome measures to strengthen the projects going forward. So in the interest of time, if you have further questions, leave them in the chat, but we'll move on to the next presentation. And thank you so much. So
Thank you.
I'm going to give you this trophy on behalf of the QI team.
Thank you.
That will be shared by Theodore.
Hello? Great. So the next presentation will be Vertigo, the Vertigo pathway. And it will be presented by Hazel.
Hello, everyone. Thank you, Dr. Law, for the great introduction. My name is Hazel. I'm a third-year neurology resident, and I want to talk about the observation pathway that we have in the ED in Kings County Hospital that is for isolated vertigo, and the patients presenting with the isolated vertigo as a symptom. So this is a snapshot of the QI project. The patients who are presenting with the isolated vertigo are going to be evaluated by a neurology resident in the Kings County Hospital. And if they are a good fit for the pathway, then we're going to start measuring some metrics about them. For our key metric for these patients that who's going to be placed in the observation pathway, it's going to be length of stay for vertigo patients admitted to neurology service as opposed to the patients placed on the isolated vertigo pathway, which is an observation unit. And the primary team for that is an EDT. And a balancing measure would be to see if maybe we're going to be accidentally putting some patients on an emergency room observation unit who are actually having a central pathology and acute pathology, most likely in stroke, and presenting with the isolated vertigo. As I'm sure you have read in the past, the patients who are presenting with an isolated vertigo as a symptom, there's a very commonly cited old study that shows the probability of seeing a stroke for these patients were around 5%. And that is very commonly cited by a lot of people. And that is the balancing measure that we might use for this project. Timeline of the project. Project started at the end of June 2021. Currently, still the protocol is active, up and running. And the people who are involved in this project is Robert and me as my co-resident, who is getting married today. So he wasn't able to make it, but so it is me and Robert as an improvement team of the neurology residents, and it's Dr. Uy as a preceptor of the QI project. So I wanted to mention the initial Pdsa cycle. I don't want to go through the entire processes of the QI that we were doing, but I wanted to mention the initial Pdsa cycle because I want to get everyone into our minds about why we did this project, how we developed the inclusion and exclusion criteria, which is relevant to the our residents and attendings who are currently practicing and involving our patients to the vertigo pathway. So I wanted to mention just the initial Pdsa cycle and how it was developed. Initially, before starting the project, I analyzed the 1 year of Kings County consultations that the chief complaint was vertigo. And that was over 200 consultations, as you would expect. That's a very common consultation that we get. And I analyzed all of these patients, and 41 patients from this approximate 200 consultations were admitted to our service because of either a suspicion of central etiology or they had symptoms that were not responding well to the symptomatic treatment in the emergency room. And these 41 patients would actually, just looking prospectively, would have fit into vertigo observation pathway. And they had a total length of stay of 76 days, just looking retrospectively. And if they had admitted to the vertigo observation pathway, they would have actually a length of stay of 41 days. Theoretically, an observation is usually a length of stay of 1 day. That is the definition of it. So that would be near 50% decrease in their length of stay. Their average length of stay, if they had admitted to general neurology service, were around 2 to 3 days. And out of these 41 patients that meets the criteria for vertigo pathway, none of them would have had a stroke on imaging. So we will be decreasing the length of stay significantly, but we wouldn't be missing any strokes on imaging. So that was our plan. And with this idea in thought, we started placing these patients in the observation pathway under the Vertigo protocol. The first patient was, I think, placed at the end of June 2021. And this is the data that I was telling you about. Around starting from June 2020 to May 2021, these are the consultations that we've gotten for Vertigo, and the blue ones are admitted, and the number represents their length of stay, and green represents that if they had admitted to the Vertigo pathway instead, what would be their length of stay. And I wanted to mention our inclusion and exclusion criteria a little bit. I'm not going to go into the clinical details of this, but the inclusion criteria is a patient has stable vital signs and has an unremarkable CAT scan as initial imaging. I want to mention more about the imaging after, because that's a commonly asked question to me about this pathway. And the exclusion criteria is very extensive, and I want to mention why do we have this exclusion criteria and why is it important. But basically, it includes symptoms or signs of having a central pathology to the vertigo. And if you have these symptoms or signs, then it wouldn't be an isolated vertigo in any case. But those are the things that we have to be careful about. If we're giving you basically the guarantee that if we admit these patients, place these patients to the observation pathway, we're trying to give you a reassurance that we're not expecting these patients to have central pathology. And this is the expectation that we have, that the patients are being evaluated for these exclusion criteria. And I want to mention, where did this exclusion criteria come from? This also comes from the retrospective analysis of the more than 200 consoles that was placed in the year of 2020 at Kings County Emergency Room for patients presenting with the vertigo as a chief complaint. And sorry about this graphic. The first one is the most important one, but you cannot see it. It actually says Unsteady Gate. And yeah. And this is a Pdsa chart that explains where can we start thinking about some red flags about vertigo. And it appears that unsteady gait was the most commonly reported symptom or sign on the neurological exam, as well as a truncal ataxia that these patients actually found to have stroke. And comes after that is a headache, which is also from the prior studies known to be associated with the worst outcomes of the cerebellar strokes if it's present. And some of them are a little bit more, as you would expect. The patient is dysarthric, the patient has altermentation, the patient has hemipresis, some cranial nerve deficits. And this is why we have all these in the inclusion and exclusion criteria. So the inclusion and exclusion criteria were developed retrospectively from this analysis, that if we do not include any of the patients that has these symptoms or signs, then we're not going to miss any stroke or central pathology for the vertigo. And with these thoughts in mind, we started placing patients to the vertigo pathway, and this is the prospective analysis of all the patients that are placed in the vertigo pathway from June 21 to at the end of May 22. There are a few more patients from this month that I didn't include because it's not completed. But so far in these 12 months, we admitted a total of 37 admissions to the vertigo pathway, and 33 of them are directly discharged from emergency room with a length of stay of 1 day. And that was a length of stay of 33 days for these 33 patients automatically. And the estimated length of stay of these patients, if they had admitted to the inpatient service, would be 100. So that is a 67% decrease in the length of stay. And there's another thing that I want to mention about the balancing measure. Out of these 37 patients admitted to the vertigo pathway, total number of patients with acute stroke on the imaging or acute neurological finding, but namely acute stroke, which is our number one concern, was 1 out of 37. And in that case, there was a breach in protocol. Patient was reporting unilateral numbness that was not resolving and was present on the exam. And there was a breach in the protocol, and the patient had someone somewhat placed in the vertigo pathway, and that was the patient who we found a stroke on the imaging. And we admitted these patients. Out of this 37, 3 of them had continuing symptoms that even after very intensive symptomatic treatment in the emergency room, that was done by emergency team, that they still had continued symptoms. So that was the reason that they had to be admitted. And that concludes all of the patients that were placed in the vertigo pathway so far. Yeah, thank you. I want to mention some other things about, and yeah, this is a graph as requested by Liz to just show you graphically why this length of stay was very significant decrease of the patients who wouldn't otherwise be admitted to the general neurology service. And the blue is the patients that are admitted to, blue is the approximate projected estimated length of stay they would have had if they were admitted, and the green is the length of stay that they had in the vertigo pathway. There's a gap that the observation unit was closed during the COVID surge, but apart from that, you can see that there's a significant gains that we acquired from this. And why was it important to begin with, and why was it important for our patients? So from my understanding, QI project can improve 3 things. It can improve patient safety, it can improve resident education, or it can improve the resident wellness. And this project specifically was important for the patient safety. And I like to think that this project improved the safety of our patients without putting them in any kind of significant risk. And the reason for that is the Kings County Medical Center is a special service that we mainly serve the undeserved and vulnerable inner city population of Brooklyn. Majority of our emergency visits are uninsured population. And there are a lot of studies that are done about this point, but it is very apparent in different countries, including United States, the patients with better insurance and from better socioeconomic background gets better treatment, better management, and better diagnostics for vertigo with much less financial burden. Just looking back to my initial retrospective analysis that I done in the initial Pdsa cycle 1 or 0, that we had discharged 47 patients from the emergency directly, and only 3 of them that actually come to our clinic to follow up further for their vertigo. The rest of them were completely lost to follow up, which I think maybe would have not happened in another patient population. So these patients, when they were discharged directly from emergency room, they did not get any further management of or workup of their vertigo. On the other hand, when they were admitted to the general neurology service or stroke service, even worse scenario, that they had received a significant number of insurance denials for this admission, which was not granted from the insurance company standpoint. And that is the financial burden that they face, even if we complete the required medical management and workup from our standpoint. So they feel better, and their imaging and further workup is looking good, but they go to their home and they still face a significant financial burden for this inpatient admission. So observation pathway is not only vertigo, but there are a lot of scenarios that we face very commonly. Observation pathways are very important for, especially in this kind of patient population, because they decrease the economic burden of the workup they have to receive, but it doesn't come with the price of missing any central pathology, missing any dangerous situations for them. So they still get their workup and management. They still feel better after 1 day of getting symptomatic treatment, and their imaging are still being done in the emergency room. But so it doesn't come with the price of any harm to this patient. And this is why the observation protocols are very important. And I would like to see in the future during my residency to develop further observation protocols in this hospital for very similar other diagnoses and presentations.
Disclosures, I love that. Hazel, what a great project here. This is just a token from the team to just say thank you for all the hard work that you've done. And for the sake of time, no questions.
Sure.
Let's move on.
Sorry, could I, Dr. Anziska, if I could ask a question? I don't think there's a real difference between central and peripheral vertigo. I mean, yes, pathways of the vestibular nucleus do give you different symptoms. But the vestibular nucleus, at least the medial and the superior nucleus, as well as the accessory nucleus in the floccular nodular lobe, can present with vertigo and nystagmus. And I'm not sure that the MRI will pick up a small lesion in the floccular nodular lobe. If you correct me on that, it should pick it up in the brainstem. I think the advantage of the unit, the emergency room unit, is a TIA, which presented with vertigo, could resolve. I would, unless I was sure that this was a primary ear problem, let's say there was tinnitus as well, I would probably treat the patient as they did in the point study. Give them a loading dose of tablets and aspirin, get an MRI, be done as an outpatient, and an echo as an outpatient, and follow them. I don't think that would add to the, I agree they shouldn't be admitted to neurology if we can get the other studies done. The reason that there's a 2 or 3 days wait is because the MRI is not immediately available. And I think patients with vertigo who don't have another explanation, such as Meniere's disease or something of that sort, should probably be studied with an emergency MRI just in case we find something, as we did with TIAs who were, when MRIs were given with a positivity rate of about 50%. So I do think that you cannot exclude at least a lesion in the floccular nodular lobe, which is a primary vestibular nucleus, as causing a vertigo.
Thank you, Dr. Anziska, for your comments. The next presenter is Kara for PEG placement pathway. I know that we're going a little over time, but we will be short.
I will speak very quickly, but can you take it out of, everyone can see my notes. I'll just use, no, but on Zoom, everyone can see. So I'll just use my phone as my notes. Yes. Okay, good morning, everyone, and thank you so much for your attention during this grand rounds. For our QI project, Mehrdad, Mali, and I have been working on ways to standardize the PEG placement pathway. The inspiration for this QI project originated from a M&M surrounding a post-NG2 placement complication. A pneumothorax developed after many readjustments in a patient who would never recover their pre-stroke oral intake. We asked ourselves, could this have been prevented if the patient was, if we were able to better prognosticate her recovery and need for earlier PEG placement? And among the many different parameters that we considered that led to this complication, prognostication was a common challenge, and it is faced by many specialties. The ability for clinicians to better predict which patient will remain with impaired oral intake and which will improve is very important. However, there's currently no agreed upon tool. Following weeks, we had a GI journal club, and I suggested that we use the PRESS score. PRESS stands for Predictive Swallowing Score. And in this single center, but multi-center validation study, 279 patients were evaluated, and they all had severe dysphagia. They developed a 10-point scoring system that considered 5 factors: age, initial NIH stroke score to assess their stroke severity on admission, stroke location, risk of aspiration using the NE2 score, and the initial impairment of oral intake. Using this scoring system before you, the researchers predicted recovery of functional oral intake at both 7 and 30 days and decided to place NG tube or PEG respectively. So now I will draw your attention to the red arrows on the graphs. Here, importantly, the researchers found that at a PRESS score of 7, can everyone see my arrow? Perfect. At a PRESS score of 7, 80% of patients had a risk of impaired oral intake at 7 days. 100% of these patients did not return to their pre-stroke diet. At 30 days, at a PRESS score of 7, about 40% of patients had impaired oral intake. And again, at 30 days and PRESS score of 7, 80% did not return to their pre-stroke diet. For this reason, a PRESS score of 7 has been suggested as our internal cutoff for earlier PEG placement. For this exercise in QI, we ask ourselves, will the utilization of the PRESS score lead to a decrease in the length of stay in stroke patients? We aim to identify earlier the ischemic stroke patients who will have a sustained impaired oral intake, to standardize the PEG placement pathway across disciplines by using the PRESS score with the GI team, SLP team, and stroke team, all in an effort to eventually reduce the length of stay in stroke patients. Our process measures include the percentage of SLP evaluations that will occur in 24 hours and the median number of days between admission and PEG placement team consult and then actual PEG placement as well. Members of the team include myself, Mali and Merdad, and our team leaders, Dr. Laws, Dr. Akula, Dr. Markadan, Dr. Nawaz from the GI team, and Dr. Banyan. During the first Pdsa cycle, we documented, or we first initially tracked the number of patients who had PEGs from September to December of 2021. And we evaluated each case for PEG placement, consult of PEG, and length of stay. Then we tried to obtain, once we obtained the median days for all of those parameters, we looked into reasons for delays in PEG placement and considered prognostication, family decision-making, and medical optimization as the top 3. Interventions planned to mitigate these reasons for delayed in PEG placement include the development of a prognostication tool, specifically using the PRESS score across multiple teams, family decision-making, giving residents and families the tools that they need to make these decisions earlier in the medical course, as well as medical optimization. We developed a care plan algorithm to help streamline some of these processes. Results of the first PDA cycle. So first, median number of days between admission and GI consult was actually 7.5. Median number of days between GI consult and PEG placement is 5. Median number of days between admission and PEG placement is 12, and median number of days between admission and SLP is 1. So also patients are getting evaluated by SLP in the first day, but then it does take about 7 days for consult to be placed, and then 5 days from that consult placement to PEG placement. The chart demonstrates the days between admission and actual PEG placement with outliers at 57 days and 28 days. Both of those cases largely due to medical complications. The patient at 57 days did have a pneumothorax, subsequent infection. The patient at 28 days had a UTI and then pneumonia. So medical optimization was really the main barrier to the outliers. Okay. So this is our proposed concept map for identifying patients who will have a sustained impaired oral intake. The points of decision making are all in the diamond. So dysphagia screen, pass or fail, what is their PRESS score? Does a family and patient agree to have a PEG place? Is this in line with their goal of care? And then does the PEG placement consulting team agree to actually place the PEG? If the patient does pass the dysphagia screen, do they need any further diagnostic imaging to better quantify their, or what level or severity of their impaired oral intake? Importantly, we have parallel processing measures. Upon initial evaluation of what we did before, many of our decisions were done in sequence, and this led to redundancy and it led to increased time to consult placement. So now within the first 24 hours, SLP eval, PRESS score obtained, using those tools to discuss both NG tube and PEG placement with the family, so that in the first day, all of these decisions are at least thought about, if not already made. It is important to also engage the stroke attending earlier. Many times when there are serious concerns from the family and or the PEG placement team, we can include the attending to help mitigate those concerns, and then discuss other palliative measurements or ways to make the patient comfortable if PEG placement and subsequent nutrition and medication routes are not provided. Next steps for the next Pdsa cycle is to engage the SLP team and GI to standardize the use of PRESS score. They are already aware of it, and the conversation about how to include this in their initial evaluation, how the GI team would include the score to help with them as a team prognosticate whether they feel comfortable placing the PEG a little bit earlier. Important lessons that I learned during this QI project is definitely spending enough time identifying the problem before attempting to come up with a solution. Initially, when we had this post-NG2 complication, the focus was on the process of actually placing the NG tube and making that safer. However, taking a step back, there are many things that led to the need for that PEG tube placement and constant readjustment. Second, planning appropriate data collection. For me, this was the hardest part, figuring out what data points I would need to collect to actually answer the question. And I thank Dr. Law for her patience with my suggestions. And then the process of the processing the perspectives of other departments when considering the solution to a common problem. With the GI conference, they were able to voice their concerns about earlier PEG placement, post-PEG complications, as well as their feeling that it does not decrease the risk of aspiration. So all of these things were learning points for myself, and I think that they're great places to bounce off on for the next Pdsa cycle. Thank you so much for your attention.
Excellent job. Before you step away, any questions from those in person? And what about for those on the virtual side? I have a question. You've already covered what you've learned and the next steps. Was there a particular reason why you were interested in this issue, and what spurred your drive for a QI project with the PEG placement?
I think the M&M was the biggest reason. Having that post-procedure complication was, I think, startling. And so trying to figure out how to prevent it was really the main driver. And it was the first time I did the fishbone diagram. And initially I thought, okay, simple problem. And then doing that exercise really taught me that it's not a simple problem. So definitely that case inspired this QI project.
That's why we use our QI tools. So great. I'm going to present you with a trophy. Thank you so much. And last but not least, we have Srinath, who's going to tell us about mobile applications for stroke survivors.
Good morning, everyone. I'm going to be talking about a study on mobile applications for stroke survivors. And the primary objective of the study was looking into the preferences of stroke survivors regarding a mobile application. So a little bit of background on why this study was conducted. And as we all know, stroke survivors can have long-term disability, close to half of them. And populations of color disproportionately have higher incidences of first stroke, recurrent stroke, and mortality. So especially in these populations and overall, secondary prevention is very vital. However, 1/3 do not follow the secondary prevention measures. The reason for that could be that almost all stroke patients, 87% of them report unmet needs when they're trying to recover from a stroke. And it's found in studies that the highest unmet need is for secondary prevention. The impediments that they face in terms of secondary prevention and their unmet needs can be patient level, meaning deficits in knowledge, attitudes, and behaviors, problems with medications themselves, and poor communication, especially with their physician. And that brings us to the question if whether there's a role for smartphone-based mobile health apps in bridging this gap and improving secondary prevention. So there are some studies which show preliminary data, small samples, which show that there's improved glycemic control, blood pressure decline, and smoking abstinence in stroke survivors using mobile health apps. However, there have been systematic reviews of all current stroke mobile health applications, which show that only less than half of them have a patient-friendly designs. Only 60% have verified scientific content. Surprisingly, only 8% were found to be very useful. And even less number of them had more than 50,000 users, and almost 80% of them had dropout within just 3 months. So the takeaway from this is that widespread adoption of stroke apps to improve secondary prevention really depends on development of the app that is driven by the actual needs of the stroke survivors. And there were no studies which were specifically looking into this. So the objectives of the study was primarily to investigate the preferences among stroke survivors for the app. And secondarily, we wanted to assess attitudes among stroke survivors for mobile health technology and ascertain differences in these preferences based on their demographic variables, and also use a software engineer to look at existing apps to find areas of improvement in their user interface. And overall, the aim was to create a framework for the development of future apps. So briefly about the methods, we started with focus groups. There were about 8 focus groups with 12 participants each, in total 96. And these were conducted inpatient as a group lasting 1 to 2 hours. And we investigated knowledge, attitude, and behaviors. And also there were recurring themes that were obtained from the focus groups that were used to create questionnaires for a national survey, which was a phase 2, in which we actually looked into the preferences of stroke survivors as to what they would expect from an app. And then after the national survey, which was conducted via email or postal mail, we used a software engineer and 16 stroke survivors who sat down in person to conduct usability testing of existing apps to identify deficiencies in these apps so that when an app is created in the future, it can incorporate these suggestions. And finally, since the national survey was conducted over mail, we wanted to conduct summative interviews over telephone to obtain supplementary inputs from patients who participated in the national survey. Inclusion criteria were age greater than 18 years, any type of stroke, ability to provide consent, and patients had to be able to communicate. So aphasia or difficulty in communication was one of the exclusion criteria. TIAs were excluded because they do not have residual deficits and impairment in function. And inability to speak English, unfortunately, was one of the exclusion criteria. Notably, lack of experience with smartphones was not an exclusion criteria, and we were able to get really good inputs from patients who did not have prior experience. So just to highlight some of the recurring themes from the focus groups, they were classified into technical, healthcare, and education and support. So an example of a technical recurring theme is the apps had to be free of cost. And some of the stroke survivors remarked that it is frustrating to pay for these apps. And another example is talk to text and voice activation. An example of health education is more information on stroke and information on parts of the brain. So using these recurrent themes, we created the national survey, a total of 17 questions, and divided into 5 major features based on the recurring themes, which I will get to later. But baseline characteristics of the national survey: mean age was 63. I don't know if you can see it. So mean age was 63, equally divided into 3 tertiles for subsequent statistical analysis. Roughly half of them were female. Most of the participants, half of the participants were white, followed by African American and Hispanic. Most participants had finished, graduated high school. And in terms of time since stroke, most stroke survivors had had a stroke about 4 to 10 years prior to data collection. And in total for the national survey, there were roughly 1,200 patients. So this is a very busy slide. I'm going to try to hide this bar so we can see the rows. Okay. So on the first column, we see the features of the app that we wanted to explore in the national survey, namely ability to schedule multiple tasks using the app, finding information about strokes on the internet, finding information about strokes locally, and also things like physical therapist, a primary care physician. So these would come under local stroke related resources, tracking fitness and diet, and communication with others and physicians. So the second column is perceived usefulness, percentage of stroke survivors who found them to be useful. And we can see that for about 4 of the 5 features, about 80 to 85% of stroke survivors found them to be useful. Not so much for communication with others. And since we're not able to see the variables that we explored, the first one is age. And we compared age of 68, the tertile of 68 to 94 years compared to a younger 57 to 67. And we noted that on univariate analysis, older stroke survivors found all the features to be less useful compared to younger stroke survivors, but the difference did not persist on multivariate analysis. Similarly, for sex, female stroke survivors found the features to be more useful only on univariate analysis. Now, I'm highlighting the influence of race on these preferences in green, mainly because this was the only variable which is profoundly significant. And we see that African American race, for almost all the features, was found to influence the perceived usefulness. The African American stroke survivors found each of these features to be anywhere between 1.7 to 4 times more useful compared to white stroke survivors. Again, time since stroke. Stroke survivors who had a stroke 10 years prior to data collection did not find these features to be as useful as stroke survivors who had a stroke 1 year prior, possibly because they had resolution of their deficits and they had resumed their normal function. And moving on to usability testing of the existing apps using a software engineer, there were 10 key recommendations about how to improve future apps. So some of the examples are simple presentation, consistency of UI across all the screens, and if possible, consistency with other apps, visual feedback using colors, and encouragement when a stroke survivor clicks on a specific thing, and accommodating for visual impairment using different shapes, sizes, and textures, and keeping things medically focused. So these are some of the examples. And finally, moving on to summative interviews, which are supplementary to the national survey. Stroke survivors highlighted the key features that they shared with us in the national survey, but also wanted to contribute a few more things, like the ability to have memory enhancing games in the app, ability to customize the app, and making the app entirely voice operable, because a lot of stroke survivors have fine motor deficits, and the ability to share the app information with the next of kin. So finally, moving on to the discussion and the summary of the study, stroke survivors were willing to adopt the technology if high cost, complexity, and technical support are addressed. And the app features that were selected based on focus groups were found to be useful by at least 80%. And age was a major divide, with older stroke survivors finding the features to be less useful. And there's definitely the opportunity for addressing that, which brings us back to the first point: if high cost and technical support are provided to the elderly. Populations of color found these features to be much more useful. And this again ties well to the general theme for today, which is equity. And I think there's a lot of opportunity again for the use of mobile health technology to bridge the gaps in these communities. Simplicity of design is important when designing these apps, and it's also essential to accommodate for all the deficits that the stroke survivors have. And finally, successful adoption definitely depends on development of the app, which is driven by these stroke survivors and their demographics. Limitations: the data collection was completed in 2017. So current perceptions of the app's features usefulness may vary. And the study, as I mentioned earlier, excluded stroke survivors with aphasia or cognitive impairment, so these findings may not apply to them. And the focus groups using which we actually created the national survey were urban and suburban. Whether these features that were selected are applicable to rural survivors, we do not know. And yeah, so these are the disclosures and acknowledgements. I really want to thank the whole team for giving me the opportunity to come on board this study, and Dr. Levine, Dr. Law, Dr. Okula, and Dr. Perk for giving me the opportunity to share these findings.
Any questions from the crowd? Okay, Minnie is the personal photographer of the group. You have a question?
For your focus group results, did you do qualitative coding about the themes that arose, and how exactly? I know qualitative coding is pretty difficult to do. I'm just interested if that was done in this study.
So all the focus group sessions were transcribed using a software, and they were recorded and they were replayed again to record the recurring themes. But it was a qualitative analysis, and qualitative coding was done. Exactly as to how that was done, I'm not entirely sure, but the recurring themes were not quantified or standardized. Just to encompass a variety of recurring themes, we did not want to quantify or standardize them.
Any questions from the Zoom room? He's right here. Hold on. Okay, Dr. Papamasakis, you're making me work for it.
Congratulations, Serena, for a nice study. I understand the data are kind of old, but in the meantime, based on some of these results that probably they were found, known previously, has any new app been developed that fits some of these, let's say, desires of the stroke survivors? Any new stroke app for to help them with secondary prevention?
Not that we're aware of. We're not aware of any current apps which have accommodated any of these findings, especially with the user interface. We were not able to find any recent apps.
So that's MAPS 2.0, is that correct?
Hopefully MAPS 2.0 is actually coming up with an app ourselves. So that's the goal.
Any more questions? I just have a comment. I'm most surprised in your analysis. The African American appears that they are very interested, intrigued, and want to have these apps. So I would just open the invitation to have these apps available at Kings County, where we serve 95% Afro-Caribbean and African American. Please just give us the app, and Yelena will make sure they download it. All right, very good.
Thank you.
On behalf of the scholarly activity, thank you so much. Okay, so that concludes everything. I just want to say thank you. I know we're well over time. I'm going to probably hear about it afterwards, but I just want to ask all the everyone else can go. Thank you so much for your time. I will ask all the presenters to come in for a photo because you need evidence that you did your project. So please, everyone come up, but everyone else is free to go. I want to thank you very much. Dr. Park, do you have any closing statements? Anything? Okay, that's good. So thank you very much for your time. It's been excellent. Everyone needs to have a photo op to show your parents.
Thank you so much, everyone. Soon we're just gonna stop our streaming, and we have grand rounds next week. It's gonna be also in person. Thank you, everyone.
Okay, everyone come for the